Good morning, good afternoon, and good evening to everyone who is joining us in this sixth and last session, this last plenary, that is going to be dedicated to urban health in Latin America and the Caribbean. Latin America is one of the regions most heavily urbanized in the world, and as a result, it is facing important health challenges, but also very important health opportunities that we need to take on our hands. And today we're going to have four fabulous speakers who are going to be addressing some of these challenges for urban health. And then at the same time, we will have a discussion about the opportunities and the possibilities that are just there for us to work. First, we will start with Usama Bilal, and he will provide us with an overview of the health profiles and their relationships with urban environments. Then we will move on to Oriel Solar, who will give us her perspective on the regional agenda to address social determinants of health in cities. After that, Joyce and John will present us some of the options for health promotion in Caribbean cities, and we will close up the session with the participation of Mariana Alegre, who will speak about grass movements for urban health and health equity in the region. I would like just to give you some friendly reminders as to how to interact with the platform. First, if you would like to select your language, at the bottom of the screen, you will find this interpretation button that you can click on and then select whichever language you are most comfortable with. I will also ask you to, if you have any questions or if you have any comments, if you would like to interact with our presenters, please do so through the questions and answers button that is also at the bottom of the screen. We will keep all of the questions for the end of the session, but please feel free to just add it at whichever times works best for you. And then I would also like to remind you that this session is being recorded and it will be available later on, likely through YouTube, in case you want to take a closer look at it, or if you have to leave early and you want to catch up with the session. So thank you very much to everyone for joining today. And I will start by introducing Dr. Usama Bilal. He's an assistant professor at Drexel University in the USA. And today, Usama is going to be talking about the state of health and the environment in Latin American cities. Usama, you have the floor. You have 12 to 15 minutes, and then I'll give you just a 1-minute warning before your time runs out. Thank you.
Hey. Thank you very much, Tona, and thank you everyone. Special thanks to all of the organizers that have put all of the work in ensuring that the conference runs smoothly, and thank you also for the invitation to speak in this plenary. So my name is Usama Bilal, and as Tona said, I'm an assistant professor at Drexel University. Behind me, so to speak, you can see the city of Gijón in northwestern Spain, in Asturias. That's my hometown, where I was born. Beautiful city of around 300,000 people, so medium size. Today we'll see what that means. And very post-industrial town that shares some commonalities with a lot of cities around the world. But today I don't want to talk about northwestern Spain. I'm going to be talking about Latin American cities, especially the work we've been conducting in the Salurbal project, looking at health and health inequalities, especially in Latin American cities. First of all, and I think we keep hearing this throughout this conference with this special focus on Latin America, the first thing I want to emphasize is that Latin America is right now one of the most urbanized regions in the world. In this figure, you can see with data from the World Urbanization Prospects by UNDP, the trends in urbanization in the last few decades and the projected trends in the future. By region, and you can see that Latin America and the Caribbean had actually have the most intense increase in urbanization during the 20th century and now into the 21st century, that it has among the highest levels next to Northern America. and that it's projected to continue urbanizing. We shouldn't also forget that other areas of the world, especially Africa and Asia, are urbanizing rapidly now. So they will eventually catch up with the proportion of urbanization in Latin America. But Latin America is not only heavily urbanized, but it's also very, very unequal. And it's actually one of the most unequal regions in the world. This map, you can see Gini coefficients of income inequality by country. And you can see Latin America here with the darkest colors next to all of the southern corner of Africa, meaning that Latin America has some of the widest levels of income inequality in the world. So we are faced with this, a region with high levels of urbanization, so tons of cities and people living in cities, and also unequal. So this has had to have some consequences on health. And in order to study this, the Salud project, which is a collaboration of 15 institutions in the US and in Latin America, set up to study the health and health inequalities and the relationship with the environment in 371 cities of the continent. I think the very interesting thing about this project and about our work in general is that we covered not only the mega cities that everyone thinks about, Mexico City, Sao Paulo, Rio, Buenos Aires, Bogota, etc., 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 the mega cities that are on everyone's minds when we think about urban areas, but also everything else in between, including cities of 1 million people, cities of 300,000 people, at the example of Gijón back here, and also smaller cities of 100,000 people. Now, what I want to talk about today is how is health, especially mortality and especially inequalities in mortality, distributed across these cities. First of all, I want to show you some of the work we conducted this last few years examining life expectancy in Latin American cities. In this figure, I'm showing the life expectancy of women and men in 363 of the cities in the project. So these will be cities in Argentina, in Brazil, Chile, Colombia, Costa Rica, Mexico, Panama, Peru, and El Salvador in that order. And every little bubble on this chart is a city. So for example, somewhere in here is Mexico City, somewhere in here is Buenos Aires, etc. And on the y-axis, you can see the life expectancy at birth in each of these cities. And for those of you that are not used to this kind of metrics, life expectancy is an aggregation of mortality patterns, of age-specific mortality patterns that tell us if someone was born today, how long are they expected to live on average if current mortality patterns today hold into the future. So they allow us to kind of represent current age-specific mortality rates into years of life. So what we can see here, first of all, and more importantly, is that within each country, within each of these columns, there is wide heterogeneity, especially when we look at men. And actually, if we look at cities, in Brazil, Colombia, and Mexico, we see up to 10 years of difference in life expectancy between the cities with the lowest and the highest levels of life expectancy. These are huge differences that actually match differences between high income and low and middle income countries, but this is within the same countries, within Mexico, within Brazil, within Colombia, and to a degree also within Peru, and to a lesser degree within Argentina and Chile. We see these huge differences just within the countries. And if we look at this spatially, this is a map showing the same data, but spatially, where each of these shapes here is one of the cities, and on the left is life expectancy for women, on the right life expectancy for men. And the cities that are more in green have higher life expectancy. The cities that are more in red have lower life expectancy. So we see several patterns here in both men and women. The patterns are pretty similar. First of all, we see that places like Brazil have a very specific geographical pattern where the south and southeast tend to have higher levels of life expectancy, so lower mortality, while the north and northeast has lower levels of life expectancy, so higher mortality. We see that, for example, Argentina has a pattern where the northern cities of Argentina tend to have lower life expectancy. And also we see that Mexico, especially in the case of men, has a pattern where both the north and the southern states have cities with lower life expectancy, as we will see later, very much linked to increased violence levels out there. So wide heterogeneity and very spatially patterned. Now, what explains this kind of differences? What we did here is we linked these life expectancy metrics in each city to characteristics, environmental characteristics of these cities, including population size, population growth, density, fragmentation of the urban extent, so how fragmented is the city, street connectivity, essentially how much connectivity there is between streets, and then last, an aggregate measure, a composite index of the social environment of these cities that aggregates measures of educational attainment, overcrowding, water access, and sewage connection. Now, what we see here is that the variable that is most predictive of life expectancy, both men and women, is this measure of the social environment index, this metric that tells us what are the levels of education, how much overcrowding there is, and how much access to sanitation in general there is in the city. We find that cities with improved levels of all of this have much higher life expectancy. Some of the other metrics also are predictive, including population growth, but none of them is as predictive as the social environment index, indicating that living conditions are some of the most important factors that predict life expectancy and mortality in general. Now, why is this happening? What are people dying from? So the next thing we did is, okay, we have this, how much people are dying in these cities. Now let's look at the causes of death. What we show in this figure is every bar is a city, it's a different city sorted by country, for example, Peru, Argentina, Chile, etc. And then the thing in green down here, the height of this bar in green is the proportion of deaths that are injury and that are violent injuries, mostly homicides. On top of that, in purple is the proportion of deaths that are unintentional injuries. Majority of these are road traffic accidents. Top of that, in yellow, are the proportion of deaths that are cardiovascular and non-communicable. On top of that is cancer. And last, in blue, are communicable, maternal, neonatal, and nutritional deaths. And in this figure, we observe several patterns. First of all, we observe a couple of things that are different by country. For example, Peru, cities in Peru tend to have higher levels of communicable deaths, while cities in Chile have higher levels of cancer in general. Now, we also observe several very interesting patterns within countries. And in particular, I want to draw your attention to the green bar down here, which represents the proportion of deaths that are violent injuries, mostly homicides, which are highly, highly variable within countries. For example, in Mexico, which we have cities up here with almost 20% of all deaths, 20%, 1 in 5 deaths that are homicides. That will be, for example, the city of Acapulco in Guerrero. Now, down here, we have cities that have very few deaths that are homicides, around 1 to 2%. That would be, for example, lowest here would be Merida in Yucatan. So we have the entire spectrum from very few deaths that are homicides to 20%, 1 in 5 that are homicides. Same pattern we observe in Brazil, same pattern we observe in Colombia, very heterogeneous levels of violence, which match very, very well the heterogeneous levels of life expectancy we observed before in those same countries, especially men, as violence is one of those things that especially kills young men, which reduces life expectancy by a lot. Now, we also link these cause-specific deaths to the social environment index that we mentioned before, that composite index of living conditions. And what we observe is a pattern that is remarkably similar. I didn't say this, but this is cross-sectional data from 2012 to 2016. This is remarkably similar to the epidemiologic transition that we normally observe longitudinally, where we observe that cities with the worst living conditions have higher communicable deaths, communicable maternal, neonatal, and nutritional deaths. And these deaths decrease in importance as we go up in this social environment index and are replaced first by cardiovascular deaths and then by cancer deaths, which increase at the later end, at the top end of this, meaning that we have a transition between these communicable deaths and non-communicable diseases deaths. Now, one of the most important critiques of the epidemiologic transition theory is what happened with injuries. And what we see here is that both violence and intentional injuries are actually quite spread out across levels of the social environment index, indicating an unclear pattern, so that cities and the entire development spectrum are vulnerable to violence and accidents. And the second critique of the epidemiologic transition theory is what happens with inequalities. So that's the next thing we looked at. First, we look at cities. Now let's look within the cities. This is just a brief example of one of the articles we worked in the last few years, where we examined life expectancy differentials in comunas and partidos and municipios that make up 6 large cities of the region. And here I'm just showing an example for women in Santiago on the left and for men in the Gran Buenos Aires, the entire metropolitan area of Buenos Aires on the right. Santiago, we observe very wide differences, with differences up to 15 years of life expectancy between the top and the bottom neighborhoods in Santiago. Santiago, by the way, we didn't go into this, but it's one of the cities with the highest life expectancy overall. But at the same time, it has some of the widest inequalities. So there is a lot more room for improvement there. In Buenos Aires, we do observe this north-south pattern that actually, if we look a little bit more in detail, we see that from the north to the south of the Ciudad de Buenos Aires, we have 6.5 miles of difference and 6.5 years difference in life expectancy in the case of men. So very striking differences. And we even went deeper. This is work that is being led by Andres Trota, was just presented in one of the presentations in the previous sessions, where we've been looking at life expectancy at the neighborhood level in the city of Buenos Aires, observing a very similar pattern with higher levels in the north, a transition area in the center, and then lower levels in the south, that are very, very strongly connected to the levels of education in those areas. And then 2020 came. All of this data is before 2020, and then 2020 hit us and hit Latin America, especially hard. If you want to learn a little bit more about how COVID-19 has hit Latin America, we have recently prepared a data brief on COVID-19 and urban health in Latin America and in the Caribbean that you can find in this link and in our website. And in this brief, we examine data across cities in the region, because one of the things we wanted to look at is, well, what about these sentences, these statements, sorry, that policymakers in the region are making, like the health minister of Chile that said there is no relationship between lethality and poverty, because that would mean there is discrimination in how we treat patients. Well, there was a relationship between lethality and poverty. Here we see how the inequalities in age-adjusted mortality in Chile before the pandemic were narrower than during the pandemic. So in the pandemic, these inequalities were strengthened, which means there has been a relationship between lethality and poverty during COVID-19. As part of this brief, we also look at how the levels of positivity varied by living conditions in Mexican cities, finding that cities with better living conditions have lower COVID-19 positivity, meaning they either have more testing or have lower incidence. We also looked at how rates of vaccination varied by comuna in Santiago de Chile, finding that the comunas with the highest levels of educational attainment have the higher rates of vaccination. Now we put all of these things together, then this scenario later will be that these inequalities are poised to even increase even more in 2021. Because if we see that there were inequalities before the pandemic, that inequalities widened during the pandemic, and that vaccination rates are again unequal, we'll have a 2021 with even wider inequities. We will call for immediate action. So if you want to learn more about these patterns and look at them in depth, we have prepared interactive applications that on looking at how health varies by Latin American cities, which we'll paste in the chat later. We also have an interactive application looking at how life expectancy varies within 6 large cities. And also, of course, the COVID-19 brief and our interactive app where you can explore COVID-19 in Latin American cities. Thank you, and I will welcome any questions later during the Q&A.
Thank you very much, Usama. And it is just amazing to see all of the work that Salurbal has done in terms of analyzing all of this information prior to the pandemic, then afterwards. And I just think that the difference that you were just showing in terms of how different the experience of COVID has been in Mexico City and in Mexico in general, and then also in Chile, it's going to connect very well. It's going to be a very good segue to Oriel Solar's presentation. So I would like now Oriel to present Oriel. She's a regional advisor of social determinants of health at the World Health Organization and the Pan American Health Organization at Santiago de Chile. And today she's going to be presenting a regional agenda for addressing social determinants of health in cities. Please, Oriel, you have the floor.
Thank you very much for this opportunity to share and to discuss in more detail. And it's a great opportunity and the great conference. No, I will prefer to speak in Spanish, for this is the Latin America session, and maybe the people speaking English, we need to select the translation, and the other people speak Spanish, listen in Spanish, no? Okay. Bueno, en primer lugar, ¿cierto?
Well, first of all, in this final session, there is a lot of the topics that I'm going to mention have been already discussed in this interesting and conference on these topics and the emphasis on equity. In this first slide, I'm showing some images of the graffitis, the urban art in relation to the social protest of justice, social topics that are expressed in many of the graffitis that we find in many of our cities, in our neighborhoods. Many of the authors indicate that graffitis are like the skin of a city, and it's expressing of one way or another these aspects that are being debated and that are being expressed in the cities. I'm going to talk about I'm going to try to summarize some topics. The first one has to see how we address the social determinants and some reflections on the agenda in the region and the need for it. The second, a reflection of what has meant the pandemic and post-pandemic and the challenges that we have and some initiatives that we have from the from PAHO, and that it's important to share. When we talk about addressing the social determinants, it's a central topic. We talk about the analysis framework that we're using, and from the different theoretical perspectives, we have these analytical frameworks that, according to the topics or to the area that we are addressing, they're going to have like a psychosocial emphasis or more on the materialistic scope, or highlights the econopolitical scope or eco-social scope, or some that have developed from the local scope or the globalization context. And maybe some of them that have been talking about the business determinants. But there are two key aspects on this framework. What are the mechanisms that generate these inequalities, and what are the mechanisms that are highlighting certain scopes of the social determinants for the impact on health? And for us, what are the entry points to address the policies and interventions, that the problems that are generated by inequalities, the interventions or policies are not going to be effective. And this is a central topic in the agenda of social determinants, on how can we address them. Many times the studies or the scopes of analysis are on what we call proximal determinants, and like a social determination origin, that have been left behind and are not visible for many of the action or necessary interventions. So in that sense, we have these questions. In that framework, what are those social determinants, scopes that we should address when we talk about a city and territories in particular? What makes the difference? And I think there is a lot of learning that we have seen in the different presentation and experiences, especially the Salurbal initiative, that has collected very useful information about the debate and discussion in a region. I have a framework that I think that represents some doubts that we have in relation to address the equality topic or justice or urban justice in our cities, and to bring this framework that has been in the conference. We find it interesting because it shows that there is an important interaction in different scopes within the territorial scope. Sometimes we highlight the physical conditions like the environment, the infrastructure, transportation, mobility, access to water, green areas, physical activity, but there are also processes that happen within the cities and between cities in the neighborhoods that are important to understand the construction of these inequalities and the meaning that it has for the communities. So that the communities and people within the cultural scope, their experiences, their knowledge in many of the neighborhoods that are like that are settlements or slums, we found many sectors of in the peripheral areas, then the migration processes that have been growing on this pandemic, and this goes along with the power. How do we distribute the power to understand inequalities when we talk about health? This power that is being shown in the networks, the access to public services, and also the capacity on the decision making on the territorial scope or the municipal scope that has to do with the policies also, and also with the decision in the different social services scopes, health, education, etc., but also in the political organizations. What are the attributions and the capacity when we talk about the territories at a local government level and the capacity that the regions have, the levels of decentralization to make decisions. And I think that many times these aspects are considered as non-independent, and this interaction to be able to see in a comprehensive way, it's very important. This is related on how we understand the territories as an expression of the well-being and the social well-being that, as I mentioned at the beginning, is expressed by the graffitis. We have seen this when we look in detail the territories. We see in territories, for example, in accumulative processes, in the environmental scope, that has to do with the social conditions and the health of the population. We have these territories that are now like the sacrifice territories where we have pollution, vulnerability, adverse conditions for health, and we also have the territories where people live. And highlighting how territories, as Border and Tovar said, this emphasis of territories as production processes and social reproduction that are the basis of how we understand social determination. And in that sense, when we see cities, there is an additional complexity. There is a multi-causality. There are different levels. There are elements that come together, and we want to give this territorial way that presents new challenges, even more when we think of some of the topics that have been presented before, what it means, the non-communicable diseases or the cancer topic, and how at some way or another they have been configuring these issues that the social transmitted diseases that are related with the urbanization process, the industrialization processes, the poverty, availability to work, access to processed food, and that some way or another are configuring certain conditions that are presented at a national level and at a territorial level that are generating the opportunity for those conditions where we see a series of problems that we have nowadays within the countries in the region, especially in the cities, and that has a base, and how can we distribute certain conditions or opportunities within the context of our country. This implies, and that also has been part of the discussion in the conference, this complex situation is to address the city. So the answers obviously will imply multi-components, several levels of intervention, the coordination problems that are related with different sectors when we talk about policies and action scopes. This idea of health that can be very different when we talk about the biomedical or the sanitary area, and how can we include other sectors outside the health sector. when we analyze cities and territories, there are pathways because we have complex context. And this is like what configures the intersectorality, and what we have called also like health in all policies. In the European experience, that it's called on putting emphasis on equity. And in the region, we had different experiences, some successful, some not very successful, in a context where the well-being conditions or the development conditions for well-being in the constitution and its formulation, it's been more difficult. So the concept of intersectorality or the coordinated work in the public sector have not had the necessary emphasis to provide a comprehensive answer. But at a local level, there is a lot of experience in the region. We have seen in the context of the response that we have given to the pandemics on this emergency situation, that the challenge is to sustain these responses going beyond of this immediate situation. So another important X when we talk about the cities and the territories and to address the social determinants has to do with the participatory processes, like from the citizens, from the communities, and with the communities. And this that seems so obvious, it's hard to develop it within the processes in a region, how we understand the distribution of power, of how to empower the citizens, the co-creation of interventional policies to build capacities for an informed intervention, and the necessary changes processes where the citizens and the community have a central role on this. So when we see the region, we see some progresses, but we also have some steps back when we see the social determinants in the region. When we see the processes that give opportunities in the region, there is a story of development when we talk about these topics, when we talk about the social topic. And it has to do with movement and the collective health and processes that have been debated, especially in the context of the democratized that we had in the last 20 or 30 years in the region. We also have an important opportunity when we had a commission on equity and inequality that talk about these topics and that emphasize the processes of the role of the indigenous population and the structural process related to discrimination. So it's also an opportunity. There has been an effort within the organization to implement monitoring about health inequalities, especially on the mother-baby area, and that's been a big effort. But the monitoring inequality, it's not enough to provide actions or interventions. In that sense, we see that we try to integrate objectives within health planning, to be able to emphasize interventions in more structural scopes, that it's more complex, that implies conflicts, debate. It's a greater complexity on studies, but it's fundamental when we want to eradicate inequities. But we also see a limited in the health sector and what models this social determinants, and it also has to do with a relation that to try to move forward with the actions. And when we talk about the information or evidence, it's not enough in some cases, but also has to do with the political will. So in that context, we have the pandemics. And as we have seen, there were repercussions in the region, especially about the mortality, but also related to poverty, what implies the growth, the increase on the workforce, the increase in employment, and the challenges that we have from now on. we have some aspects that it's an important crisis. We can also see it as an opportunity. The pandemic put in evidence what we knew, that we all had some progresses in the region in the last decade. These were very weak and fragile. And on this situation, put into evidence the inequities in the region. And there is a structural inequity, and this cannot be avoided or not visible nowadays. There has also been more interest of all the sectors to talk about the public health topics because of the pandemic. So this brings a possibility and a new opportunity when we talk about the leadership and the health role. About this debate about economy and health has been present, and it gives us an opportunity on how can we understand the health construction processes related to development. We also have, it's been evident also, and it's been very clear in many of the examples in the region, and especially is in different examples that have been pointed, is that, the effective response to the pandemic, it's not enough if it's just limited to the care services or hospital care, or just related to mortality associated to it. It is necessary public health actions during the pandemic. It requires action in those conditions that allows that implementation. And we've seen that it's been evident how the social topics, how the employment protection topics, how the food protection has also been very important when we respond to the pandemic's access to water, something so basic, shows those gaps that we still have. So it's also an opportunity in this context of the last year pandemic. The group related to health promotion and social determinants work really a lot with the groups that were vulnerable groups. And we talk about vulnerable groups, talking about the vulnerability of social conditions, and not just talking about people. And in that context, we saw how the vulnerability goes more than the individual risk, talking about the social conditions, and not just that of comorbidities, of any risk of associated conditions. How can we relate the social with the biological? How the context is a fundamental aspect for the effectiveness of the intervention, how the contexts are considered in the design of the interventions, and the importance on the research topic to understand its effectiveness, how it's necessary to adapt the intervention, and how can we prioritize health with inequity. We have worked something that I have already heard in the previous sessions, these different levels that we have seen during the pandemic, and that shows clearly what we have seen on social determinants, the pre-existing sense of structural inequities for those groups in a region where we have this an important prevalence of population that participates in informal work with no rights, no social security, that puts them in a risk or in crisis situation. They are not protected at all. So how these conditions are barriers to be able to implement the measures that we recommended from the health perspective. So there is a bigger risk of exposure for these social groups. How can these situations are translated into the conditions that have been documented, the situations of the neighborhoods in which the life conditions, the access to water, and the crowding conditions are more difficult to comply with the measures, so it makes them more vulnerable. So how can we this add up what we have showed at the beginning that has to do with comorbidities, but the social conditions are related. So I just want to highlight some of the initiatives. In the urban health topic, there has been an strategic within the region that was launched in 2011 and that will finish this year, that had some progress and implementation processes, not everything that we wanted to, not everything that we hope to have as an adherence, but it was an opportunity because we learned a lot and a lot of experience. many of what has been exposed in this conference allows us to have a different point of view, bring some learning, and to propose a new strategy to strengthen the concepts of equality and social determinants with that it's more comprehensive. So finally, the opportunities that we have found are certain initiatives that have been developing within the region. We have an initiative that has to do with urban governance that is financed by the Swiss cooperation that emphasizes how we see this urban governance to accomplish well-being and health, and how we address the equity topic itself. In Mexico City and Bogota, it's going to go to 2028. So it allows us a series of possibilities on construction, assessment, intervention, where many times and many of these initiatives or projects and research, the time is limited. So the possibility to assess our interventions and to do a follow-up, it's not what we want, but now we have a great opportunity on this initiative. In second place, something that I want to highlight is that recently in the last World Health Assembly, there has been a new resolution on social determinants about health, and this highlights again, highlights the need, the necessity to address social determinants to respond the health problems and the inequity in health. So it highlights the inequalities in health. How can we work with other sectors? So it's important, the intersectorial work, and to monitor not just the results of health inequity, but also social determinants related to it, and call us to be able to consider this in the context of the response to the COVID and how to recover after the COVID pandemic that will bring enormous challenges in response. And also just a second initiative that we are yes, that will end up in 2028, and that will be developed in 5 countries in the region: Costa Rica, El Salvador, Colombia, Peru, and Chile. And that has a characteristic elements of structural scope, as are the low employment, unemployment, migration, and also and the informal settlements. This will give us a great opportunity on how to understand the base conditions that are related to barriers of social conditions of the person that are associated to what we call demand, and the coordination and integration of public policies and the intersectorial work, and also a fundamental role in the process of social participation. It has research, training, knowledge transfer, and it proposed models and prototypes that are going to be tested, and it's a great opportunity. This will reinforce a plan that will respond, a plan for the region and also for the city. Thank you very much.
Gracias, Oriel. I'm going to switch back to English now, and I would like now to present Dr. Joyce and John, the Executive Director of the Caribbean Public Health Agency in Barbados, and today she's going to present promoting health in Caribbean cities. And Joy, I would just like to remind you that you have 12 to 15 minutes, and I'll give you a 1-minute warning before your time runs out. And I'll also ask you if you could speak, a little bit slowly because of the translation services. Thank you very much. You have the floor.
Thank you so much. And let me share my screen. Thank you very much for the organizers to give the Caribbean Public Health Agency this opportunity. I am based in Barbados at present, but I will soon be going back to the headquarters, which is in Trinidad. So that explains my beautiful urban scene. And so these are some of the things that I plan to tell you in my 15 minutes. And I am going to let you know first who we are. And we are the amalgamation of 5 regional health institutions, very young, operational since 2013. I've been the executive director for 2 years. And this is who we serve, 26 member states, mainly English speaking, but there are also French and Dutch speakers as well. So a quick look at determinants of health, the overall perspective. And then we went closer into the issue of what are the determinants of a healthy Caribbean urban setting? Because I'm talking about preserving health in the Caribbean. And you see the big four for us: climate change, the globalization of determinants of health, the burden of chronic disease and risk factors, tourism and travel in the economy. So what I'm going to tell you is a little bit about these big four and what we are doing to ensure that we address these and to keep everything in check. So urban living is a major determinant of health. And so we are in the regional and national public health arenas going to be trying to improve living conditions, housing, employment. But wait, health has no control over this. And this is how it becomes evident that the role of health is not always in service delivery, but also in influencing policy and in influencing programming. So we'll look first at tourism and urban health, because our region, our sub-region of CARICOM, is one of the, if not the most tourism and travel dependent for our economies. And so what we've been going through during COVID-19 has not just been an issue of closing borders, but there has been a huge threat to our economic stability. And we know that urban settings demand a lot of funding and social services support. So for us, we have looked at ways in which we can try to mitigate those threats and risks. One of the things we've done is actually work on improving the tourism product. So the CARFA Tourism and Health Program has worked with tourism partners in the region, Caribbean Tourism Organization, Caribbean Hotel and Tourism Association, the Organization of Eastern Caribbean States, GTRMC, CRC, to try to come up with standards and ways to improve tourism so it's healthier both for the tourists and for the workers. So this is one social determinant that we've worked on, but there's also the issue of what the health systems have to offer. And in the Caribbean, we rely very heavily on primary health care. It's a strong pillar of health, it's cost effective, and especially so in the urban setting. So although we know that the epidemiological and geographic transitions, that is that we are becoming aging societies while we are having more urbanization, while we know that these are colliding, we're also trying to make sure that the sectors who can determine the urban health are coordinated and advised. So we look first at the built environment, and we look to see how we can have accessibility for differently abled people. Because an aging society means that you're going to have people who need support to move around. But at the same time, we need to find a way to preserve biodiversity, because we know when we encroach on habitats of other organisms apart from humans, what can happen? COVID-19, for example, that would have jumped from an animal to a human because there wasn't that look. So there is that need for not just looking at built, but also what is the biodiversity we can preserve. And these recreation spaces are not just for physical health, but also for mental health. And of course, the whole issue with the built environment, healthy food access. So we worked through the policy perspective, and I give the Barbados experience when they were developing their latest urban plan. There was wide sectoral discussion, and there were active attempts to integrate what is going to be the kind of healthy public policy for a healthy urban space. And it involved the policymakers and the civil servants. We also have to have a look at vector-borne disease, because this is one of the climate change effects. And in the urban setting, there's a lot more opportunity for breeding. So of mosquitoes and also for other vectors like rodents. So CARFA's vector-borne disease strategy is very much based on a multi-sectoral approach, and therefore ideal for looking at this through the lens of social determinants of health and improving the urban setting. So there's been a great attempt at intersectoral coordination, evidence-based decision-making, and building of workforce development capacity, because it's one thing to deliver services, but it's also important to give people the tools to protect themselves. And of course, there's integration of climate change. We've been working with the Caribbean Institute for Meteorology and Hydrology at looking at the factors of weather and climate that affect health and giving forecasts. So these are some of the key activities that we've been conducting in the member states. So it's all about capacity building, getting equipment, ensuring that you are keeping track of your indices, and developing work plans. And in this regard, we have been well supported by the European Union. So this whole issue then of multi-sectoral action, and this is an illustration of when different agendas collide. And here you see a boardwalk, Barbados again. This was developed to reduce coastal erosion due to wave action. Also one of the fallouts from climate change and sea level rise. But people realize this is something lovely. And it has become a spot for exercise. So here we are looking at this whole issue of our physical health. But we have been very lucky in CARICOM. The heads of government have been clear in their statement from as early as 2007, and you can see the heads. We will promote policies and actions aimed at increasing physical activity. Now we talk about what is happening with the pandemic and how the CARICOM region is responding. It is because of the unity of the heads. It is because of the whole of society intervention that they have mandated. And they have mandated the CARICOM institutions like CARFA to ensure the support to the member states. So isn't it a good thing that we were able to get that kind of political vision? Because you know that the CARICOM countries have really bad issues with NCDs, non-communicable diseases, and their risk factors. And this whole issue of insufficient physical activity is illustrated on the right. Now we've got some of the Latin American countries woven in, but we have some high levels of physical inactivity among adults. In Suriname, Bahamas, and Barbados, they have the highest prevalence. But we still have a global target to reduce by 15% physical inactivity. So this whole issue of inactive adults is unfortunately mirrored in the adolescent and young population. There's also high levels of insufficient physical activity. So without clear and strategic urban planning, then we have another reason for a setup of this long-standing tsunami of NCDs. So these are some of the actions that we have put in place to promote active cities. 85% of non-Latin Caribbean countries have population-based physical activity awareness programs. And we're talking about increasing the availability of public spaces, which are green, creating walkable cities and walk-only zones, the use of opportunities to integrate multi-sectoral action, joint action with all those sectors, and the use of shopping malls. So you use what you have. And with climate change, this whole idea of indoor activity in cooled spaces is something that we have to think very seriously about. But there's also the issue of food insecurity, and this was something which was exacerbated by the COVID-19 pandemic. We import a lot of food in the CARICOM sub-region, $5 billion annually. Some countries import 90 to 95% of what they consume. And so this issue of supply chain breaks and how it could have affected food security was one of the reasons why we had some government mandated a food security policy to match what was happening with COVID-19. There's also the fact that we've had the shift in dietary patterns to high consumption of energy-dense, nutrient-poor, ultra-processed foods, which worsens the pandemic, worsens the outcomes for COVID-19. Sorry, worsens the NCD pandemic, worsens the outcomes for the COVID-19 pandemic, because NCDs feeds into your outcomes. And we've been seeing younger and younger people affected by COVID-19 and not surviving. So the Food Security and Livelihoods Impact Survey of last year, 2020, said that approximately 2.9 million people are estimated to be food insecure. And the pandemic has pushed a rise in food prices. As well, there have been job losses or cessation because, for example, the tourism sector, which is a huge employer, just wasn't functioning. So nearly 1/3 of respondents said that during this pandemic period, they'd actually been skipping meals, eating less, or going a day without eating. So in order to ensure urban food security during the COVID-19 time, we have to be looking at ways, and this is CARICOM-wide, of preventing supply chain disruptions, ensuring food safety, combating malnutrition and hunger, administration of phytosanitary, because we don't want to provide anything that will harm our citizens and the health outcomes of people with NCDs. So the whole promotion of healthy eating, community backyard and home gardening, all of these are some of the ways in which health is trying to influence other sectors to ensure that we have what is good to eat. And the promotion of an essential basket of healthy foods is part of our work with the finance ministries. So we'll need political commitment and governance, increased access to resources with equitable distribution. This thing of equity, especially in an urban setting, will not go away. And improved knowledge and evidence on regional food and nutrition security. So let's do a little bit on climate change and WASH. So water, sanitation, and hygiene and the work on climate change is also part of CARFA's remit. And there is a nexus between climate change and WASH, and the events that are precipitated by climate change, flooding, hurricanes, sea level rise, and drought, are also making it difficult to have a strong WASH infrastructure. Sorry, let me go back again. But we are still trying to do our best to ensure that we have a handle on and ways to address decline in water quality. We must protect, maintain, and manage water and sanitation, infrastructure and services. And in that regard, we have had some strong networks of WASH in the region, and I'm talking about the region of the Americas, which have worked very well, even in the emergency situations that we've seen with St. Vincent and the Grenadines and the volcano, and also the record flooding in Guyana late. So the collective term goes, let's boil it down to simple things. No toilets, contaminated water sources. No clean water, no basic hygiene practice is possible. So safe wash is also a prerequisite for health in the urban setting. And this clean water, sanitation, and hygienic conditions are essential. They're key for disease prevention and suppression. And so, along with all of the traditional clinical medical models, we have to look at this whole issue of environmental health, wash, and sanitation to reduce the risk to human well-being, social and economic development. Because in preserving health in an urban setting, you're also preserving regional development. And so I think we're going to be ending off with hygiene, linking it back again to COVID-19. COVID-19 put basic hygiene on the map. Again, it's embarrassing, but it took a pandemic. And we need safe water to provide the kind of proper hand washing and hygiene. And therefore, the look at how these things are administered and maintained in the urban setting has been really, I think, one of the positive. I say that COVID has many silver linings, but this is one of the silver linings that has come out of the pandemic. And where there wasn't good infrastructure, there was the input of alternatives and the teaching to all age groups of the alternatives to ensure hygiene. So it's been a behavior change driven by a virus. And in a way, we've got something that usually takes a long time to happen quickly. And it's about being consistent in messaging, working closely with communities, studying existing beliefs, defining motivation strategies. And so I think that this conference and this panel have highlighted some of the really important ways in which determinants of health can be affected by drastic situations and seek to correct some of the inequities that will ultimately undermine regional development.
Thank you so much, Joy, for your intervention and for pointing out these problems and challenges that we share, and also to give us, a quick overview of the very specific problems that are being faced by the Caribbean cities. I would like to remind our audience of the possibility of writing your questions for our participants today. You have a button at the bottom of the screen where you can write your questions, and then at the end we will present them to our colleagues. I would like now to move to Mariana Alegre. She is the Executive Director of Lima Como Vamos, Occupy Your Street in Lima, Peru. And today she will be speaking about grassroots movements for urban health and health equity in the region. Mariana, you have the floor, and I'll give you a 1-minute warning close to the end of your time. Thanks.
Thank you very much for the invitation. I'm very happy to be here. I know you have asked for everyone to put a photo of their city as a background. I decided to put a public space picture. So my presentation is in English, so I can make it either in English or Spanish, as it is what is more comfortable for you all. I don't know, so I will go in Spanish then, and then you can follow me along. Bueno, primero, muchísimas gracias. Yo soy Mariana Alegre.
First of all, thank you very much. I'm Mariana Alegre, and indeed, we wanted to tell you about the pandemic context, or what the pandemic context meant for our country. And I know that the first presenter mentioned this when he visited our country, but mainly we wanted to say that this mandate that came with the first quarantine of a stay-at-home was impossible for many people, and because there were people who just couldn't stay at home due to the quality living conditions that they had. And then when these measures are actually when the pandemic started settling and we realized that it was going to take a while, we moved to a model where we had to, okay, do not stay at home, but stay in your neighborhood. But how can we do it in such a context of such an inequality or injustice? Next slide, please. And when we look at images from our cities, we here will see two very important pictures about the type of public space that we have. And this presents a very complex scenario where the public surroundings, the quality of a house in the basic services are extremely different depending on where you live. And we have these two neighborhoods. They are 15 minutes away, one from the other, by car, and you can see very clear differences. And this repeats throughout Latin America. Next slide. So from a process where we have a context in which social security and public health is precocious, where we have overcrowding in houses that generates more contacts, and we have multiple families living together, when we also have a problem related to the provision of basic services, what can we do in order to address the problems that come from the pandemic, and also understand that it's not just a public health matter, but also public development that has been unaddressed for so many decades. And it is how part of the process that we want to go create, implied to generate capacities to create scenarios to recover the streets, but also to understand the value of a public space become more and more important, particularly at some points when citizens were told to just stay at home all of the sudden. And when all of a sudden they understood how valuable the spaces were. So in that sense, we created that public space policy was going to help to address not just the COVID, but also to provide some social justice to the people, and also to promote and reactivate the economy, which is still very pending for the whole world and for our cities in particular, considering the high informality rates that we have. And it is within this context that we have a series of promotions, let's say, to address those who need it the most. And this is based on an urban node strategy that allowed us to promote and see what are the existing relationships in the neighbors. Next slide, please. That could also help to address the crisis due to these diseases, but the crisis due to lack of employment and due to the closed economy that we were living on. And from there, we started having scenarios and examples from different magnitudes and different ways. Here in Pamplona Alta, we are developing a comprehensive strategy to address the people's needs. This is an area that doesn't have water or sewage. And in the picture you see in the middle, we installed one is what let this what we call a common pot that we know this was a practice also installed in many other countries, and it's in that sense that the capacity that we have to have an impact and incidence in individual experiences goes beyond public policies, and obviously goes beyond the real capacity of the government to address with resources people's needs. This is another example of the processes that we promoted in the center of Lima downtown. But it's clear that an exercise of monitoring these community kitchens was deployed in our countries, and also the strengthening of these neighborhood groups was not going to go far if we couldn't have any influence in public policies. And that's how we started promoting a national strategy for public spaces to make the government understand and particularly Peru is in a crisis. At that time, we also had another political crisis, but this allowed us to reach to highest levels of government and tell them what was the actual need of reactivating cities, and this was related to a public space strategy to address mental health and people. They was related to obesity, recreation, physical activities, and of course, on open areas had less chance for infection. So in this sense, we work to promote, and the Ministry of Housing has created several packages to use the street in different contexts. We're still pending it to use the street for learning within the context that public and private space, where public and private schools are still closed. And in that sense, we needed to promote and provide safe settings to address the people from the public service distribution strategy. And the idea was to take to people whatever they need from the real possibilities that local governments had. And it's within those lines that a part of the exercise has us to do with the potential resources of the national government. Here we see some of the things that were the deployment as we had in these roads, but also we started having to work with local governments, and in that sense, we had a pact for public spaces where several municipalities in the country joined us to manage the public space that it made sense, not just to recover the streets, but also related to public health, because they had to understand that it was necessary to rethink and reconfigure the public spaces in benefit of the people, and as our and also for walkability, or for walking and having walkable streets, and also. Next slide, please. And my last message in this case is that we know the pandemic was a tragedy, but the capacity that we had as a country to generate and accelerate some processes that had been driven related to sustainable mobility, public spaces, of accepting that recreation activities, physical activities, cultural activities can occur in public spaces. And in that sense, we made really good progress. Hopefully, this is not considered it was just a solution for pandemic times, but it's something that stays in benefit for our citizens. Thank you very much for everything.
Gracias, Mariana. Thank you very much, Mariana. And I would like now to open the floor to questions and comments that our audience could have. And I would like just to remind you that you can do that by clicking on the questions and answers button that is at the bottom of your screen. If you have any questions, we will take them at this point. So please go ahead. Perhaps in the meantime, while people, warms up to the idea of asking questions, I would just like, to start by commenting that it is really, really amazing all the work that everyone is doing, and it really makes me feel that we can create long-lasting change. And perhaps that's one of the biggest challenges that we are facing in urban health, right? So we have groups that are doing research, and groups that are trying to improve things, and groups that are planning, that are thinking on the big picture of urban health. And I would like just to ask our panelists, how do they foresee, these interactions between different types of actors that are relevant or important for urban health? Do they see, like a very clear pathway for this interaction? Do they think that we need to create these types of spaces in a much more clear way? And perhaps this is also a good opportunity for Ariel to comment a little bit more about this project that WHO is undertaking to increase leadership in cities, and also for Mariana to give us, her ideas on how can we create more meaningful, more impactful collaboration. So please, whoever wants to start first.
Yo puedo comentar algo. Okay, I will comment something. And, well, bueno, en primer lugar, con respecto.
First of all, in relation to the projects, we have this opportunity for the ones that are doing research in the country or the region. This urban project that we have from now until 2028, and also the project of social determinants that it's focusing on also territories, because it's going to be developed at a local government levels, the municipalities, and it has been defined as a territory for the conception of how we understand territories as not just an administrative space, but how the social conditions and the interactions define the results in relation to health. In that sense, you can ask, there are several initiatives when we talk about training. There are many spaces and opportunities at a medium and long term, and about the challenges to work with different sectors. Just to highlight that when we work about working with different sectors, it's a negotiation process with different sectors, with different cultures. So there is this topic when health, the health sector, it's the central, but maybe it's not central for the other sectors. So how can you find that common element that can add initiatives or that can make synergies within these initiatives? Because when we talk equality, there is not always a win-win with the initiatives, but there's no doubt that one of the topics that we are particularly interested in talking about the projects and both on social determination is to know in more detail what is the perception the decision makers have in relation to equality and social determinants, and also the concept that they have on urban health. Because if we don't have clear the knowledge, the myths that are related to these topics, it's going to be difficult to involve or to add policies or political will or understanding on these topics. So I think there are lines that we still have to develop. Thank you.
Mariana, would you like maybe to precisely trying to create these groups, that are capable of generating change, and after you will open the microphone for Joy. Yeah, go ahead.
Yes, of course. Well, first of all, I think it is not creating the groups, but actually being able to identify them and recognize their leaderships, and of course, helping them with the resources they need. We do not have the time to create anything, and we are not part of the actual groups or the movements in those areas. So what we have done is to activate or to empower the persons that have been already leading these type of groups, and of course, being the facilitator in order to take the resources that they need, even though sometimes it's of course money, and we are scarce of money too, but we can find alternatives, ways to help them. As an example, either from material and donations, or maybe they just need to have some pressure into the mayor to actually be heard. And that's the type of activity that we have done. But what I want to address is that it is quite important for the process to actually involve citizenship. Communities and people have a strong voice, and they need to be acknowledged as what they are, which are people with rights, and have the respect they needed to be given, which sometimes we cannot find that simple issue in some politicians or in some people working on grassroots processes.
Thank you very much, Mariana. Joy, I can see your hand is up. Would you like to comment now?
It's not a matter of creating groups are working together, and the ways of working are out of necessity changing. So I think it is more a matter of using those connections to improve the urban health. And she just made a really good point. In the pandemic, the role of social media and the voice of people on social media has really done a lot of the decision making about population-based behavior change. And I think that politicians have realized, you know, there's a lot of talk about top down and bottom up, but I think it is more about shortening the space between those who make the decisions, the policy decisions, and those who are affected. And social media and the voice of people has become organized because of COVID-19 to be more strategic about getting what they need. So apart from the new ways of working in sectors, both public and private, who make the operational and infrastructure changes, we also need to involve the community groups, citizens, and young people in this whole thing about insisting, I will not accept this. We must go to this way of behaving or this way of changing so that there is equity. Over.
Thank you very much, Joy. We have a couple of questions in the Q&A section. First, I have Andre Ann, and she's asking, she says, thank you for the presentation. My question is for Ariel. Can you speak more on the integration of an environmental justice lens in your understanding of health equity issues? And the next one is also for Ariel. And Ana Ortigosa is asking if you could share the site or the website to know more about the projects in Mexico City and Bogotá. So please, Ariel, go ahead.
Ok, gracias por la pregunta. Bueno, nosotros entendemos la justicia ambiental desde la perspectiva del lente equidad, en el sentido que por justicia social tenemos mecanismos distributivos, digamos, de beneficios y oportunidades para el conjunto de la sociedad, y también en materia de resultados, ¿no? Entonces, de una u otra manera, cuando hablamos de la justicia ambiental, nos referimos en cómo hay condiciones, digamos, de justicia distributiva con respecto a las condiciones ambientales, y cómo en aquellas situaciones o territorios de impacto hay mecanismos de redistribución con respecto a dar oportunidades frente a este deterioro, ¿no?, ambiental y de condiciones sociales, ¿no? Y por lo tanto lo vinculamos fuertemente con el concepto de justicia social, ¿no?, con respecto a reales oportunidades del conjunto de las personas, a ambientes saludables y que desarrollen más salud para el conjunto de la población, y por otro lado, el que tengan beneficios vinculados a situaciones de daño o deterioro, ¿no? Con respecto a los proyectos, yo creo que quizás nos pueden escribir directamente, ¿cierto? Tanto a Fernanda, a Gary. No hay en este momento una página propiamente tal de la región, estamos en construcción de la web. También hay un link vinculado a la iniciativa global, porque esto también ocurre en otras 2 regiones, pero la mayoría de las ciudades y países están en la región de América Latina. Así que por favor nos escriben a Fernanda o a Gary, que tienen sus correos, y coordinamos dudas o consultas, ¿no? Gracias.
Thank you, Ariel. Thank you very much. And Joy, I can see your hand up, but I don't know if it was the last one. I think it was. All right. Thank you. Thank you very much. Usama, at some point in your presentation, I mean, you gave us, you know, like a very quick overview of this great analysis that Salurval has been doing for life expectancy and for different causes of mortality now, COVID-19. I was just wondering, you know, since you went over that so quickly, if you could maybe share with us what are the next plans and what are the types of questions that you would like to maybe look into, you know, like a smaller detail. Please go ahead.
Yeah, thank you, Tona. So it's I think a lot of people are doing very different things, but some of the things we are trying to do is kind of get a little bit more detail with the geographic scale. I show a hint, for example, of those analyses in Buenos Aires, where we are able, instead of looking at large comunas or municipalities, we are able to look at neighborhoods, which allows us to kind of tackle that issue of, you know, there are certain cities where, for example, the downtown area is huge, like thinking of Brazilian cities, etc., where, for example, the downtown of Sao Paulo, the municipio of Sao Paulo is like 12 million people. So in those cases, being able to examine neighborhood level variability will give us great hints on how wide disparities are in those areas. So finer geographical scale is one thing. The other thing is finer temporal scale. So being able to look longitudinally at these things, how have things changed, whether policies have had an effect, whether there are potential issues. Some people in Salurval are looking at heat and how temperature has an effect on cities and what factors of cities mitigate all of those kind of things and how are inequalities behaving under those kind of things. So I think having a finer geographical scale, having a longer temporal scale, and last, having a clear focus on inequities and health inequities is the other thing that Salurval is expanding, right? Like having those three dimensions, but combining them too. How do policies affect inequities? Not only how do they affect levels of health, who's benefiting from all of the policies that are being implemented. I think those are three key things that people are working on, but many more, of course. I think during this conference, people have seen several examples of this kind of thing. So, and one thing that on the more personal, I think one of the key things that this kind of research projects can do is get to the public. And answering the previous question, which wasn't for me on the first one, but who should we be talking to? And I think the public is the key stakeholder in all of these things, because the public is the one that at the end ends up building the political pressure for the decision makers to do things. And if the public thinks that health is a matter of hospitals, we don't have a lot of work to do. We have a lot of work to do in this space, because we should shift that. If people think that inequalities are not something that we should worry about in health, then we have a lot of work to do. If people think that climate change is completely separate from health, we have a lot of work to do. I think the key thing we all must be engaged on is making sure that the narrative of health as socially determined permeates with the public, that I consider to be the most important function in public health and urban health.
Thank you very much, Osama. All right, I don't see any further questions in the Q&A section. So perhaps it is time for us to start closing up, and I would like to start by thanking all of our panelists today and for their presentations. I think it was really amazing just to see the, like how diverse and how different, and at the same time how similar the challenges and the opportunities that we have for the region are. So thank you very much, everyone, for joining this afternoon. And I will just leave it at the point where Osama was talking, right? So we need to pay a lot of attention to the public, and we also need to be very comfortable embracing diversity, complexity, and make an effort to integrate our knowledge. So thank you very much, everyone. Have a good afternoon, and hope to see you in the next session. Bye.